Good afternoon, everyone. So great to be with you all. And what a privilege we have to hear from Dr. Nigam Shah today from Stanford. We are going to be diving into all things healthcare. It's obviously been an AI. It's obviously been an incredible week with markets roiling over some incredible advancements, and we look forward to diving into some of those as well today. We are going to start with an introduction. He actually probably doesn't need much of an introduction, but Dr. Nigam Shah is the professor of medicine at Stanford University, and I believe the first chief data scientist for Stanford Healthcare, a position he's taken up in the last year or two. He has had a really robust research career. I remember when I was at Stanford a decade plus ago, I think at the time, was just being brought in and has been doing some incredible research in AI. And then, of course, we all got advanced with the launch of ChatGPT, and that's done nothing but accelerate his leadership over this space as we really for the opportunity to use AI to really advance our ability to diagnose and treat and really reach the opportunity for precision medicine. He is the inventor of several patents and has done some great work to also launch several companies to advance this space and was elected into the American College of Medical Informatics in 2015. Without further ado, take it away, Nigam.
All right. Well, thank you for the wonderful introduction and audio and video coming through okay? All right. So I have about 15 slides. We'll try to go through them as soon as possible and make most of the time for question answering. So let's jump in. So this is perhaps, I would say, the most important sort of conceptual slide I can share with you all. Everybody talks about AI and strategies and integration, and somebody somewhere will throw in digital, and then there's this mix of is it data science and whatnot. But at the end of the day, what is happening is we have this lived experience of a patient, which in this case is represented by an arrow of time going left to right in black at the top. And then things happen, like a hospital admission, an ICU stay. Things happen outside the health system too, obviously. We don't typically talk about them, but you could take a very comprehensive view. And then, depending on what happened where and where you are in the ecosystem, we collect certain data. So on this particular screen, which is a sort of an idealized version of an ICU stay, we're seeing some waveforms like ECG recordings, respiratory rate recordings. There might be some heart rate recordings like numbers of some kind, vital signs, lab tests, progress notes, medication orders. And if we spend 20 minutes just on this, I would bet we could enumerate, yeah, I don't know, 50, maybe 100 different kinds of things that we like to measure. Um, every hole in the body, we can send a camera up and take a video or a picture. Yesterday, there was a surgeon showing me videos of like a tiny hole at the base of the skull, and they're operating on like the trigeminal nerve. And video of a little, like a 3 millimeter space at the base. Uh, Two things remain true about this thing. Let's give it a name. We call it a patient timeline object. The two things that remain true is if you take any modality, something as simple as heart rate, there is nobody who has a complete longitudinal 5-year record over time. People have parts of it. And the other thing that remains true is if you take a point in time, no one has all modalities collected on the same person at the same point in time. Again, stands to reason, we don't do an MRI on everybody that walks in the door, and we're not going to take an X-ray or order all the 500 lab tests we know how to do on the same person. We collect what's needed. And that's really important to keep in mind because we're going to take these things, these objects, patient timeline objects on millions of people and squash them into a flat table and then build these things we like to call models. And often somebody somewhere we say something like, oh, there's this data is missing. Now, from a clinical trial perspective, whenever some value is absent, well, it should have been there according to your trial protocol, and it's no longer there, hence it is missing in the true sense of the word. In an observational setting, missing could have two meanings. One, it was supposed to be there and it's not there. Or two, somebody made a conscious choice. It's not needed. That's information. So in my medical record, like in my timeline like this, you're not going to find a troponin measurement. But if you then try to impute it from similar patients on whom it was needed, you might impute a false value because in my case, a physician deliberately chose this person does not need this measurement, meaning it's not needed. So something to keep in mind. All right. So we take these timelines and we build models. And I've sort of parked models here in this little tiny corner. They could be logistic regressions or they could be deep neural networks and they could be token models. They could be whatever. Right? We're not worried too much about it right now. In my mind, a model is essentially an object to which we feed a new patient's timeline, processed in the appropriate manner, and the model gives me back a number. In case of language models, the numbers then get converted into a text that's converted to a paragraph, but at the base level, you're outputting a number, a probability. And then using that number, I would argue that in medicine, we make two decisions and only two decisions. A decision of whether to treat and how to treat. And the whether to treat can be further decomposed into, I'm trying to figure out what the patient has, also called diagnosis or classification. Or you're trying to figure out what's going to happen to the patient, called prognosis or prediction. Or you're trying to decide a treatment. Now, at any given point in time, there's multiple simultaneous whether to treat and how to treat decisions to be made, and they often conflict with each other, and that's why medicine is hard. But at its essence, we're trying to make these three things. Also worth noting that in general speaking, we would say things like a sepsis predictor. In my mind, that's a crime against logic. There's no such thing as a sepsis predictor. It's a classifier. The model is trying to tell us the patient has sepsis. You have not yet figured it out. So by definition, it's a diagnosis task and not a prediction task. Prediction is something that has not yet happened. In case of sepsis, the only prediction is sepsis is there. You have not yet diagnosed it. So in reality, it's a classifier. And we abuse language quite a bit in this manner. So it's really important to tease apart what are we doing in terms of the timeline. Are we diagnosing, predicting, or recommending? And the reason I bring this up is about 80–90% of things we do with models are actually diagnoses, just masquerading as predictions. And then we can do these things, diagnose, predict, or diagnose, prognose, and decide in the service of advancing the science of medicine and aspire for a Nature Science Cell paper or a Nobel Prize someday, or advancing the practice of medicine, which is a JAMA, Lancet, or New England Journal paper, or the delivery of medicine, where you may or may not publish. Maybe you write something in Health Affairs, but most often you go to Sand Hill Road here and raise some capital and try to make healthcare cheaper, or depending on your incentive, more expensive. The reason to bring this up is often when people talk about strategies and innovation and all of those fun things, they assume that if you make an advance here, you automatically advance delivery. And nothing could be farther from the truth. Just to hit home this point, there's this disease called heart failure with preserved ejection fraction. And a group of scientists at Northwestern did this elegant study showing that this one disease, this one label is in fact three heterogeneous conditions. And if you are subtype 1, let's say you're dead in 2 years, and subtype 3, you're fine for a decade. It's an advancement in the science of the disease. Practice would advance if I get two more things. I have a test. Could be a blood test, could be an AI test on the ultrasound, on the EKG, doesn't matter. It could be multimodal. Patient walks in, I order this said test, and in 5 minutes and spending $2, I know whether they're subtype 1, 2, or 3. But then I also need a treatment. If I treat the three subtypes the exact same way. All we've done is increase the complexity and cost of care. So to advance practice, I need test and treatment. But to advance delivery, I need to do that test and treat regime for 5 years for 5,000 people, and they live longer or cost less or both. Then we have advanced delivery. And we often make this assumption that advancing one is advancing the other. So that is also something worth keeping in mind. All right. So when Jared was here or just about to transition to the East Coast in the amazing cold there, I have to say that I was working on this particular project here. It was this idea of using aggregate patient data at the bedside. Right now, if you have a question, a physician might consult their colleagues, sort of reflect back, how many other cases that have I seen? The idea here is to consult your database, your electronic medical data repository, and provide an opinion saying what happened to similar patients. So we did that for about a lot of tech was built. And then in 2018, we launched a proper service, which could be paged and consulted, just like you could call cardiology, for example. Um, and we would provide a report. We did 100 such cases and wrote this New England Journal Catalyst article, and then spun out a company. All right. So why does this matter? Like, there's lots of math and science and sort of fun computer engineering we could talk about, but why? So on the left is a study I was not involved with, where a few clinicians monitored for about a week how many decisions they're making, and then found retrospectively, there's a sort of were surveyed and say how many of those decisions had evidence. About 80% were deemed by those same physicians to have no basis in any prior published data. And less than 3% had a study specific to the question at hand. Now, maybe evidence existed and these physicians did not know, but even if the number is half, and instead of 80%, it's 40%. I mean, that's still a pretty big number where we're kind of unsure of what to do. And so that's the thing this startup does. And of course, ChatGPT came around and I said, guys, you shall not use it to make answers. So they listened. It only uses GPT to illustrate or elucidate the question. The rest of the analysis is done in the same rigorous way that happened in the New England Journal paper. And you can basically get a report of similar patients in a couple of hours. Okay, so let's look at another quadrant. Let's go here. This is about making predictions. So this is a study at Circ with Arnie Milstein. Circ was just mentioned in the intro. Here, we're looking at those patient timelines and making a true prediction that who is going to have this thing we call a cost bloom, as in is going to become a top decile cost member in the next year. So we did it using Danish data at that time, and then U.S. insurers found out about it, and Prometa Blue Cross said, "Will it work in the U.S. data?" And I said, "I don't know. Give me the data." So they gave me the data. Then I said, as a faculty member, "Give me funding." They gave me funding, and we did a pilot that showed that it also worked in the U.S. data. But then prediction is only as good as your ability to act on it. And as a professor, I could make predictions and write papers all day long, but that's not going to make any difference. So we spun out another company which makes these cost predictions and works with insurers and care coordination companies in order to intervene to make the prediction wrong so that the person would get timely care. Now on this side, in the prediction side, well, it turns out the model, this thing here is the easy part. I can build 50 models, no problem, telling you all sorts of things, that patient's going to have an ED visit or they're going to have a diabetes crisis or what have you. No problem. Readmissions, The value of this AI-guided work depends crucially on these two things. Like, what is the action we're going to take? And what is our policy and work capacity? Work capacity is really important. So for example, and the company, which I think I forgot to mention the name, Prealize Health is the name of the company. So I'm going to give a non-company example just so that there's no COI there. Let's take a company called Vizii, not involved with them in any way. They have a model to read a CT scan and tell you whether it's a hemorrhagic stroke or a ischemic stroke. And if you happen to be in Central California, there's a policy that says if you have a hemorrhagic stroke, we can fly you over to UC Davis in an air ambulance, and somebody can drill a hole and get the blood out, and you have a better outcome. So the action and policy are in place. But then there's this matter of work capacity. How many air ambulances do we have? If 3 people get a stroke and we only have 1 air ambulance, only 1 person is going to get that benefit. And I'm giving a very dramatic example to hit home the point about this next plot, which is that once we have the model's output and we rank order the list based on probability of having that forecasted event, that's on the x-axis, then we start taking action. Benefit accrues, that's on the y-axis, cumulative utility in whatever numbers that you please, dollars, time, lives. And then as we march down the list, utility rises for a while or benefit accumulates and then starts going down, diminishing return. So that's we hit a max and then we start going down. What matters in that example I gave is what is our capacity? How far down the list are we going to go? And that is the single most important thing that is necessary to be aware of when thinking about using models. And so this interplay, the model, work policy, and the action, we've been studying it for a while. We've come up with a framework for evaluating fair, useful, and reliable AI models in healthcare systems. That's actually the title of a paper, which brings me to sort of this visual. We call it a firm assessment. That's why the first letters are in bold, fair, useful, reliable models. And we ask a whole bunch of questions in these 3 buckets, trying to figure out essentially, what is this plot going to look like? That's the bottom line. That given our work constraints, given our capacity constraints, policies, our patient mix and everything, do we have the ability to go down this list and achieve some benefit? That's what all of this analysis is done. In parallel, we look at ethical considerations up front. And we also make some financial projections, as in, can we sustain this long term? Again, that's kind of folded into the usefulness estimate, but it also is helpful to clarify upfront. And then we make a recommendation on what should you monitor for prospective evaluation. Because often things get deployed. I'm sure your health systems collectively do all sorts of pilot projects, and then you don't really know which one's actually impactful, which one should stay on, and which one should be shut down. So we decide those criteria up front before making the deployment. So all of this is like about a decade of work that I just zoomed through in a couple of slides. And we figured out this form assessment business. We started doing these form assessments. The team started in March 2022. First 6 months, we did 6 assessments, and November 2022, along came LLMs. Well, it turns out these things have been around for a while. My research team had been studying these sequence models, as I like to call them, as opposed to just language models, for quite some time. Our first paper was in January 2021. But then the rest of the world found out, and we said, all right, what do we do now? So first thing we did is that, well, how are people testing and evaluating healthcare applications? Now, the papers didn't come in this order, but this is the order in which the narrative makes more sense. So this paper came out in 2024, which is a review of about 519 papers asking 5 questions. What data were used to examine the functioning of a language model in healthcare, EHR data or something else? What was the healthcare task? What was the language task? What was the metric of evaluation? And which specialty? 5 things. So the first one is not on the slide here, but 95% of reported studies did not use EHR data. So it makes you go like, what? The healthcare task, that's about 20 of them are right up here. The most common healthcare task is answering USMLE questions, and we call it enhancing medical medical knowledge. And then making diagnoses, educating patients are sort of the next two big ones. The language task, not surprising, question answering, a few information extraction and summarization tasks, and very little conversational dialogue being evaluated. We love talking about accuracy, and we do not pay that much attention to how much is going to cost to deploy. Is it calibrated? How stable are the outputs? And things like that. There is not great, but enough focus on fairness, bias, and toxicity. You see that here, but not much on these two things. All right, so that's the state of affairs. So then we said, okay, what if we start using these at the bedside? So we just take off-the-shelf LLMs. There's a bunch of studies. I'm only showing you two. In the first one, remember that green button project where, the green button project, Atropos Health, where we had these questions that came up at the bedside. We took those questions and submitted them to GPT 3.5 and 4. So, this one is GPT 3.5. This one is 4. And we showed the answers to 12 clinicians. And we had a reference answer. Whether it's true or false, let's not argue about that. But let's say we had a reference. And we asked the physicians, is the GPT answer agreeing, disagreeing, or you can't tell? And from GPT 3.5 to 4, agreement is up, disagreement is down, unable to assess is down. So that's great. But about half the time, the 12 physicians could not agree what was the case. It's like having a very confident person at the bedside, and you can't tell whether they're right or wrong, jokingly referred to as a second-year med student sometimes. So passing exams does not imply bedside utility. All right, so then we said, what else? So here, people are trying to do care coordination, they want to do triage, they want to make treatment recommendation, all sorts of things, right? So we asked 15 clinicians to give us some prompts, like this one, summarize from the EHR, the strokes the patient had and their associated neurological deficits. Then we showed them a medical record, and then they wrote out this yellow box. We then gave the same prompt and that medical record to a language model, which writes out the green box. And then we asked the physicians to review and say, all right, what does it look like? Short answer, even in the best case setting, when we did this work, it was a 35% error rate. And this project is called Med-Align, MED Align, Med-Align. So how aligned are the outputs to our medical use case? So medalign.stanford.edu, even the data set is released. All right, so before we close out, I want to sort of bring it back to this patient timeline. And this timeline has a language, and I put language in quotes here because when people say language, most often we think English, Spanish, German, something like that. Here I'm talking about language in the computer science sense. Any finite sequence of tokens from a defined vocabulary. So in our case, the vocabulary or symbol set is ICD codes, CPT codes, RX norm codes, and so on. In case of a protein sequence, it's amino acids. In case of a DNA sequence, it's DNA nucleic acids. In case of English, it's like words in the Oxford English Dictionary or what have you, right? So we have this sequence of events. So why can we not use the EHR as a language? And I'm not talking natural language. That's why I keep putting language in quotes. This is a sequence of tokens. Well, then if we have this broader view of language, we can have applications to documents, and that gives us what we traditionally call language models that chat with us and do summarization. But we can also feed these timelines, and that gives us these things which, for lack of a better word, we call them foundation models. They'll help us forecast what's going to happen. I can train these things to say how many days will pass until a certain token, like a heart attack, shows up in your record. So if we take that worldview, I'll just show you one slide. Like, what are the benefits of thinking a little bit broader in terms of language? So what we have on this plot, the x-axis is number of examples I have to train a classifier or a predictor of some kind. The y-axis is performance. The red, cyan, and orange are traditional methods, gradient boosted, regressions, random forest. And then the blue is the timeline trained model. And you can see that at any given sample size, it performs better. Fine. That's a lot of compute. But the big news is that even with just 64 samples, 64 training examples, this timeline way of building models gets you as good performance as a random forest trained on all the data. I mean, that is amazing. 95% less training data, trains 8 times faster, and of course is 3 to 19 times higher accuracy. So there's some value in sort of not just blindly using the technology, but asking what is the underlying guts of it that we can adapt for our use in medicine or healthcare. You don't have to believe everything I say. All of these data sets that we talked about in terms of showing these models perform better are publicly available. You have to sign a DUA and so on. So here's Novelline, that instruction following, and these two, earshot and inspect, allow you to verify the claim I made in the previous slide. And they have images and tabular data, notes, and all of that fun stuff. So I'll close out with this, that in the land of language models, just like those for traditional models, we have that Mercedes-Benz logo of the three-pointed star of model, work policy, and action. Here, I think we have to think about building models in a way that matters for us, but we also have to think about how do we verify benefits. I don't think the claims being made today publicly have much substance in them, and we cannot ignore the deployment and maintenance costs, and how do we do that responsibly. And we wrote all of that up in this special communication in JAMA, which, by the way, our CEO and CIO are co-authors, which is awesome. So I think this is my last slide, and happy to take questions.